Welcome to the May Fireside Chat. We got Dan Thompson with Vensure Employer Services. Uh-oh, big speaker echo. Is anyone else having that?
No, I don't hear echo.
No? Okay. Ward, I don't know if that's a double a double speaker thing you've got going on, but if anyone else is hearing that, let me know. But welcome to the May Fireside Chat. I got Dan Thompson with Vensure. So known Dan for a long time, and it's kind of a unique guest because their employer plan uses 6 degrees, so they have that experience, but they also act as a broker and sell 6 degrees. So he's seen it from both sides. He's seen it and heard it from their clients, and he's seen it and heard it from their employees. And I think that just provides a really unique experience and perspective that he gets to share with you guys today. So I had Dan out to our symposium in frigid Sundance, Utah, here this last winter, and spoke to our group that was present there and did a phenomenal job. So I think it's going to be a neat fireside for you guys to sit through. Please ask questions as we go, and we will answer those as the session goes through. So Dan, welcome to the fireside chat. Looking very dapper. You're my
Thanks, man.
inspiration.
It was a
In
little
fact,
cold out here on the beach. I started the fire and then for some reason it
put a
just
jacket
stopped
on. Yeah,
still. It
yeah,
stays in that area like that, but it is keeping my back warm, so that is nice.
yeah. And I know you're always encouraging me to get my steps in. I have 3 times this week so far. I've been getting my steps in. So back on the Dan Thompson program. So
Yeah, well, nobody's perfect, but I do get my 3.5 miles of walking in almost every single day, regardless of where
uh,
I am. If it's a hotel, I looked at my Marriott app. I had 191 nights last year in Marriott's, which is insane. A lot of Delta points, cool Delta experiences, but I don't know. I don't have anything against American Airlines, but just traveling can eat at you. But if you don't stay walking
yeah,
and moving, you're just toast. So yeah, I
for sure.
appreciate you putting together the Fireside series. I really enjoyed being in Utah, and yes, you're right. For those that don't know me, Dan Thompson. So I'm technically Chief Benefit Officer for Vensure Employer Solutions, which we just celebrated I think it's 113th acquisition in the last 5 years. So I'm also division president of Thompson Risk. If you look at this crazy list of names, I think it's row 4 over here to the right. Thompson Risk was my second agency I created with the idea of really focusing on fully insured employers and trying to help them move to self-funding where I can. But as most brokers know, you also have, all of us, a lot of us independents have a very large fully insured book. And these days, it's starting to go crazy with ICRAs and level funded and all these other things. And I'm seeing much more acceptance, and that's a positive thing, of employers to start thinking about reference-based pricing. I think RBP was way ahead of its time. But thank you, Heath, for giving me the opportunity to tell a little bit about the Vensure story. I'm not only and by the way, my hair is real, but it's like the hair club commercial. It's like not only am I a client, but I'm also I happen to, as Heath said, be a benefits broker of a couple decades in addition to an employer.
So I just so you know, and I don't get on LinkedIn probably as much as I should because I'm like the yellow pages era of people, but um, I just posted something the other day because 6 Degrees has its own RBP plan and it performs wonderfully, and all of our employees are on it. And that was my thing. Like, remember the old hair club for men commercial? Like, I'm not only a president, I'm a client, and it made me smile thinking of it. Now you just pulled it out just now. So great
well,
minds, great
let me tell
minds.
you, LinkedIn wise, and we'll jump right in. LinkedIn, if anybody saw it, especially brokers in the room, Trump RX just came out and there was a nationally televised introduction ceremony or session where Trump was talking. And at the podium was also Dr. Oz, obviously, you know, the Honorable Mr. Kennedy, who's running Health and Human Services, but also Mark Cuban. And the point of by the way, also the CEO of Amazon Pharmacy, and they were talking about the celebration of TrumpRx.gov and how that's going to help people change the game. And I thought it was cool because it was bipartisan, right? Mark obviously voted for Harris, and Mark's been kind of seemingly out in the public space anti-Trump, and obviously Trump was sort of anti-Mark. But the two of them shared a podium together for the greater of good to be able to help people everywhere look for lower, more competitive drug prices. And so, of course, I don't know. I have a small followership, and I go on LinkedIn on occasion. It's the only thing that I do, and I put a small notification there about Trump RX and talked about Cuban Cost Plus and Amazon and what that's doing yesterday. And for whatever reason, LinkedIn picked it up and dropped it into their national news reel. And by morning, I think it had like, I don't know, 8,000 views. And of course, every anti-Trump person forever is commenting on it saying, well, Trump this and Iran and blah blah blah. I'm like, oh great. Now my post is now wound into like this versus that or him versus her. And I'm just, if you're seeing that post of mine, I'm neutrally responding to saying, hey, look, put your politics aside, bipartisan. We need to fix healthcare. We need to fix prescription drugs. It's clearly a problem. We know how to fix it. There's a lot of great advisors on how to do that. So like it's just makes me miserable to think that I'm going to get yanked into a political vacuum. The more apparent the work you're doing is a good thing, and then the more partisan yank and pull on you. So I want to. I'm a registered Republican, but I want to live kind of in the libertarian world in the middle. So that's where I am these days. But any rate, I've had the pleasure of being involved in Vensure through all the acquisitions of these payroll and PEO companies and technology providers. In fact, many of you know who have joined about AIM, and we also acquired AIM also from a care management standpoint. But when I first got involved in Vensure, this was part of the presentation in Utah. Their internal plan, I changed their internal plan to a self-funded health plan, and as I always say, kind of as we bullet point these, like, it speaks to the power of RBP. And I want to speak to what the actual administration was, right? The 6 Degrees Health experience. And then what did it look like, through the good and the bad and the ugly? And then obviously other successes and challenges with things like point solutions. Um, so this is a funny slide, and I got her permission to use her face, and she was like, "Oh God." But Chris Hansberger up on the right, she's become an executive vice president for me and our team. One of our top three of our 440 benefit employees. We have about 6,500, almost 7,000 domestic employees. 16,000 when you consider worldwide, but it's getting even bigger. I think it's closer to the 7,000-8,000 now with all the acquisitions. But in July of 2018 to July of 2020, right? This was about 1,000 employee fully insured group. And they got a double-digit increase. Gee, surprise. And they moved to a fully insured alternative with Aetna, which also got a double-digit increase. So Chris was one of the original employees of Vensure. She was actually in charge of both client-facing benefits and PEO with all the small PEOs they were buying at that time, and also in charge of employee-facing benefits. She now is fully in charge of our internal health plan. So works with me, works with 6 Degrees and AIM and all the other vendors like Regenix and Green Imaging. And boy, we dive into all of them. And so I said to her, I said, are you ready to move this plan to a self-funded plan? It was, 5 years ago, but I walked into her office and she was like, she had that look on her face, like that famous meme that I used on this slide. Like, are you kidding me? You're gonna kill me with this. So I did it anyway. And even though, sometimes the best way to do things is just fierce execution. And that is the hardest way to do things often. But, what we did was we built a self-funded plan using a lot of the next gen strategies. Obviously, 6 Degrees is a huge part of that. We use Cisco as the TPA. And I just literally ripped the Band-Aid. Like, goodbye, Aetna. 40 states of employees, some of the really tough rural areas, Billings, Montana, rural South Texas, West Virginia, Beckley, West Virginia, some places that didn't even know what in the hell RBP is. And we just did it. So we enrolled about 1,016 lives that were on before. We only did reference-based pricing with 6 Degrees. We created a kind of a something I always wanted to do, right? This is one of the first ones I did it on, and a big one, plan design steerage. If you call the nurse and she recognizes centers of excellence for you, could be 5, 6, And you pick one and you go to those facilities, we waive your deductible and out of pocket. A lot of people call it vanishing deductible, right? Do whatever you want. You can call it David Copperfield deductible, doesn't matter. Adjectives are always fun. We put in USRX care, we use AIM. Script sourcing is mandatory. In fact, actually, when we started, it wasn't mandatory, but I'll get to that and tell you why that's important. And so now I'm going to talk about the lovers and the haters. So, and I probably did this at the summit because it was in person, much more better of entertainment, but I would say, wait for it, wait for it. It's like the scene in Braveheart where they're holding the stakes down and the guys are galloning, coming across the field. And he's like, wait for it, hold, hold. And they pull them up, right? And then, all the guys run into the sticks. One of my favorite movies.
Yeah.
So, what's the downside of a huge Band-Aid rip like this, right? We all call it the noise, the guided plan. Poor Chris, I put that picture over there. She's screaming, right? Acquisitions are rolling in. Venture's buying payroll companies, PEO companies, 50 employees at a time, 200 employees at a time, 250 employees at a time. She's got open enrollment like freaking Groundhog's Day every month, having to re-educate and re-educate and re-educate 12 times a year, 12 months a year. Providers started to resist. Employees were being uncooperative. Like, this isn't going to work for me. I didn't have this where I came from. And then I was dealing with all my board of directors. There's about 40 now, but executive buy-in ish, right? Some of them were like, okay, this is good. Some of them were like, this is bad. And then, of course, where the noise was in the beginning, and you learn trial by fire, no pun intended. PCPs and GYN selection was a disaster, right? My doctor's not going to take this. What the hell? I'm not changing doctors. ID card issues not being recognized. Problems with call the nurse. I think for some of the brokers here, you may have experienced that before. And then extremely overwhelmed HR. I'm talking like do more with less in the worst type of way. And I'm sure Heath, as you talk to so many advisors moving their practices from like traditional buying to an RBP, this is probably like the lion's share of the stuff that they're dealing with, right?
Oh, I think so. I mean, it varies from group to group, and it has a lot to do with the depth of the HR teams. And we look at it as we've got to be prepared to be able to step in and assist as needed. We do have most people probably don't know this, but we do have a kind of a buy-up program that allows us to embed somebody in larger plans, just to deal with the RVP component of HR. But it's at the same time, when you've got somebody like an expert like yourself on this, that not always necessary either, right? You can help provide some of the answers, guidance, and security to those looming questions that otherwise can unravel a plan if it does go unchecked. So
Yeah, no doubt. Well, at this point, I, of course, having been fiercely the fierce person who executed this, was nervous. Like, what am I going to do next? So the fixes have come along for many years, right? So this is years of learning trial by fire and what the fixes were. I'm happy to tell you that it's the same plan, and we just renewed. Not to fast forward too fast, but I'll share a little bit of the good news, right? Because we just shared the oh shit moments. But 1/1/26, we renewed 0% increase to our guided plan. We did implement. I'll kind of go through this, but we did implement at one point a Cigna alternative plan, but we jacked that 25% to try to discourage people from taking that route, but to encourage people to take the RBP plan. So the fixes were, look, we studied behaviors, right? And I encourage every advisor to talk to your HR teams and your clients. Like 70% of Vensure population didn't have PCPs, right? So they're all using GYNs, PAs, NPs, ARNPs. They're going to urgent cares for acute care. They're not using primary care doctors. So we decided to implement something there where we made it not necessary to be worried about those aggregate claim noises, where we would cover anybody. PCP, GYN, those are all small dollar claims. There's no need to, nitpick with people of whom have seen the same GYN for 20 years or the same PCP or PRNP or an urgent care. So we made that all they can eat. And by the way, it didn't affect the numbers at all. Contribution strategy, right? We want to contribute more to the guided plans, the plans that have the RBP. We improved the call the nurse so much so that we ended up acquiring the damn thing. So we brought the AIM team in, and since then the AIM team has scaled to both a Columbus originated organization, to both having nurses in the East and West Coast and also near shore, to provide more scale and be able to get to phones faster, react faster, including technology. And that's vital in today. So we now have an AI team working with AIM to create applications that allow people to get centers of excellence recommendations instead of the old way, calling AIM, waiting for a callback, or emailing. That's going to be gone very soon. In fact, we're coming into the last few weeks of trials, but we will be rolling that out on more of an AI basis, where there's an application with a personality that says, "Who's the best cardiovascular surgeon in Washington State?" Boom, that's the one I want to go to. Boom, it's going to be super fast for authorization numbers, unlike we've ever seen. A 20 to 23% shift every year over to the guided plan. Why are people doing that? It's because people are talking. The experience is better, not just for the company's expense side of the balance sheet, but the employee experience. I've had people who, you know, went to a higher quality oncologist who had seen a shitty oncologist and had a massively better outcome as a result. Same thing with endocrinology, musculoskeletal, and that's a really big one, right? Finding the right type of orthopedic surgeon who may or may not want to do surgery. Maybe there's alternatives to that that are a lot less expensive when it's not necessary, is a absolute key function. And we've had thousands and thousands of claims. I think last year was around 8,000 claims. So you can imagine our database is very juicy when it comes to practical and real experience. Can't emphasize enough educating, educating, educating. Solutions providers can help. And our HR team digs in. They work tight with script sourcing. They work tight with 6 Degrees. And obviously leveraging super users who give us the permission. That's something that's very big. What were their experiences? And largely, why did they have the experiences that they did? 6 Degrees team is massive help. And I don't have any firsthand experience with any other reference-based pricing vendor, nor would I want to, after the experience that I've had. The negotiation process is A+. Emails come. It tells us what the net Medicare rate is for that. It gives us the option to negotiate or litigate. Luckily, we haven't litigated any. And our balance bill rate is less than 0.25%, which is nothing. They also have helped us do single case agreements. So if you're an advisor listening and you haven't used RBP, don't be too hung up that RBP is just one thing. RBP is an experience. So when you have a large claim occurring, let's say, for instance, in a rural place like West Virginia, right, CMAC or Charleston Medical, I think it's the Charleston Area Medical Center, they could be really tough. Not to be granular about that particular one, but it comes to my mind because in some cases they played ball with the stated 220% of Medicare cap or 190 for professional, but sometimes they wanted to hit us with 350 and fight. And then it became, material to the 6 Degrees process that they just want to give a discount, which still was a higher net multiple of CMS. So we're constantly negotiating with providers and making sure that the employee doesn't get caught in the middle. And then obviously discounts too. Sometimes it does work out that the discount's a little better than what the net Medicare was. But we expanded our team internally, and that's something you should encourage your clients if they have positive surplus like our plan has had, and I'll get to some of the numbers in a minute because numbers don't lie. Use some of that to invest in more people to make the quality better. Target marketing for script sourcing, that's been huge. So script sourcing alone doesn't do anything. You have to engage in their campaigns, mailers, lunch and learns. You have to have HR believing and understanding in the savings and the dynamic of using MAP programs, IPP, local domestic reduction programs, copay cards, coupons. You have to have them bleeding and understanding that functionally their role has a massive material impact on the balance sheet and the health of the employees. Ours don't know anything else. Ours Our people are completely clued into the sheet music, that script sourcing, they don't want to do it any other way. And that's how you got to get the clients convinced.
Hey Dan, I don't know what you're going to say here, so hopefully go down the path I'm hoping for, but speak freely. Um, I know that we have developed a lot of member services, plan services since the time that this plan went live, and those are designed to kind of auto fire to make the easy button easier on HR. As you guys went through the process with 6 degrees with SCAs and balance bill resolution negotiation process, have you guys kind of expanded the parameters in which you've authorized 6 degrees to work, or have you kept it tight? And for the audience, I'll say that we allow this customization so that if you've got a group that really wants to be involved, if you've got an advisor that really wants to be involved, we can make that as a checkpoint back to either one of those to get our marching orders, or we can preset, what those would be so that when some of these disruptive points come up, we know what we're authorized to do on the plan's behalf. I'm just curious what the learning curve looked like for you guys there.
Yeah. In the beginning, because we weren't as familiar with it, and nor really was I as an advisor, this is like 5, 6 years ago. The parameters we set were not to exceed 220. So if 6 degrees can handle it up to 220, we don't want to hear about it on the inpatient. And then the outpatient professional services is 190. And if it got up to not to exceed, we didn't want to hear about it, just process the claims. And largely that functioned pretty good. But I would say even today, with a couple more, enrollments than we had in the beginning, almost 2.5 times, it's probably 5 to 6 times a week that a provider comes over the top of either a 190 or a 220. And we want that communicative ability, but we still expand the services with 6 degrees on that. So our responsibility, right? Advisor, this happens, we're also the client, but my role and then Chris's role as EVP is we communicate on Teams. We say, hey, did you see that claim on such and such? Yeah. You see it was 360% Medicare? Yeah. Should we fight it? Well, the net amount of additional due because it's 360% Medicare is $114. Okay, shit on it. Just pay it. So then we say, hey, 6 degrees, just pay that. We're good. $114, not worth my time, not worth Chris's time. Now, a little, contrary to that, if something comes over and it's 650% Medicare and 6 degrees, like, hey, we're willing to literally put on the red gloves and fight this for you. What do you want us to do? We go, okay, well, go and fight it. We think that that's unacceptable. Come back and let us know your result. Takes a few days. They go back to the provider, back and forth, back and forth, back and forth. You know what? Providers come back to 6 degrees and said, hey, we'll be willing to do a single case agreement. It nets if you compare the math to maybe 260. Okay, well, what's the difference between 260 and 240? It's 40%. How much is that? Okay, it's $15,000. Well, this person's already down the track with a pregnancy, and it's a facility that they already are indebted to, and they've already been down the track. I'm not going to uproot a mom at the damn near full term of pregnancy just to save 15 grand. I'm going to look like an idiot. I'm going to create a PR issue, cost me millions. So the answer is go for it, right? But if it's something else that deals with something that could be paused, like a pending surgery that's not a pain-causing situation where a person is waiting in dire straits, we would say to that person, okay, give us a minute. We're going to talk to AIM. 6 degrees pauses. We go to AIM. We say, what other practitioners could work for this? Get those options, counsel the employee and say, hey, look, we really know that you've been down the track with this provider, but here's what it means. This is the cost. It's excessive price gouging. Are you okay with that? Or there's others over here that could be a single case agreement. If it's musculoskeletal, we use Health Me. Health Me is fantastic. We've done like 7 claims with them where it's just a single bundled rate. So yeah, I hope that helps kind of give more granularization on expansion and contraction with 6 degrees, but your team is phenomenal.
Yeah, no, I mean, you guys kind of went through the learning curve, and we have best practices that we can set up for new groups. And I think some of the new groups you've sold, you've kind of followed that directive in terms of kind of getting to that point early on. And you don't always have an expert like you on those internally to work with those groups. And so we can put other stopgaps in place, like our MediShield product that just automatically takes over a balance bill once you get to a certain point and really creates an easy button for people. So
Yeah,
I was just
and
curious.
also too, I'm really starting to get intrigued about the Medicash product, where
Mm-hmm.
you have everybody on the call. I'm sure they know if they've done RBP. You have that one stubborn provider who person shows up for an impacted wisdom tooth extraction that was previously green light for quality and green light for RBP, and the provider says, "I'm sorry, but our in-office policy is I need $2,200 today." And you're like, "Oh no." Right? In AIM, we call it stay but don't leave, right? It's hard to get somebody to do that psychologically, like, oh, they're all pissed off. They call HR, they're blowing me up. But Medicash allows that $2,200 accidental charge to suddenly be resolved. And then on the back end, this gets the person in, out, gets the care delivered, resolves the issue so it doesn't become this hyper crazy negative HR issue. So that is something that I think you guys are, I haven't done yet, but we want to implement for the group that we just did so.
Yeah, Medicash been a big hit. We launched it this year. Some of the newer plans implemented it already. Some of our legacy plans are in the process of bringing it on as cases come up where they need it. But it
Yeah.
allows us to manage that transaction in real time. So
So, for those that are on the call that are probably like me, I like math. I was never good at it in high school. Actually, I sucked at it. I looked at like my old tests my mom still has. She likes to throw them in my face from like second, third grade where I had like huge F scores. I had one that was like the teacher wrote an F like in blue, and I was mad, and I made it a B in pencil. And like my mom always says to me, like, hey, this is the one that you tried to tell me that you had a B on, but the F was really in blue and you did the pencil to make it a B. I guess that was part of negotiation. But math doesn't lie when it comes to RVP, right? So, looking at these claims, it's a lot of numbers here, but the things you want to look at are just as an example, down here at the bottom, look, from 2021 through 2025, over here down to the right, our plan has averaged a net CMS multiple of 128%. Why would you ever put a large group? Why would you ever put a large group in a BUCA plan? It's a legitimate question. And I still have a lot more BUCA plans than I do RBP 6 degrees. I think what we're all seeing in the dynamic of the country today with increases is going to cause us, this is going to be a new norm, right? I hate to use paraphrases like that, but it's true. How would you continue to sustain double-digit increases? We're broker for 14 master plans across nearly 70 PEOs. The average master plan was hitting SMBs at 35, 28. We had one that was a baseline 9.5. Those are small, non-self-funded eligible groups that a lot of them we move into level funded where we can, and obviously retain some of the other book. But look, the large ones, if you're 51, 100 plus lives, this is table stakes. So I think if you're just one piece of advice, and we talked a lot about this. In fact, one of the reinsurance brokers was in Utah, and he was like, Dan, what does that mean at the bottom? And I said, well, the way I look at this from a board member perspective, when I go to our board with our private equity companies, of which have been sending me their portfolio companies to do, because they're like, this is mind blowing. That is $220 million in additional enterprise value. Now, I'm just saying, hypothetically, look at the total savings, right? Take the total savings, which is an OpEx, that's an operating expense, multiply it by 10. Industries today have come down a little in multiple. That's why you don't see a lot of, you still see a lot of M&A activity, but real big transactions are taking a little longer because there's sort of a little pause in the market. That maybe 5 years we're getting 12 to 15. Now they're getting 6 to 9 multiple. There's still deals being done in the 10 to 12. But use a 10 on this. Take the expenses how you like. If you want to look at total savings as it compared to maybe the previous plan and net that out, multiply that by 10 and see what reference-based pricing can do from an EBITDA, a multiple of enterprise value. What do you think, Heath?
I like it. I should bring you into all my finalist meetings, let you talk to the
Well, the
C-suite.
CFOs like this. The HR directors don't care. They look at that and it looks like one of those, like pictures that when you stare at it, it starts to move. And they're like, it's not moving. Well, no, we'll go over to the warm and fuzzy slide. We'll get away from that.
Yeah, the warm
So
and fuzzy is more on the HR side, but you'd be surprised. Some of them they want to understand why they're doing it, and if
sure.
you can help them translate the financials and what that means back to an employee, whether it be lower expenses for them, more people on plan for their family, all those things matter to
Yeah.
HR, and that's a financial component.
I'm
So
a lot of people don't know this. I put it on the silly LinkedIn, but I'm a big baseball card guy. I'm a 90s era growing up guy, but I'm also was even though we have a client, you probably heard of it called Nintendo, and we handle their employees in Latam. So we do cool benefits for their Latin American employees. They're selling gaming systems down in Latin America now, but I had to put, for those of you that are close to my age, almost 50, who didn't play Mike Tyson's Punch Out when they're younger? I did. But
yeah,
I think from a 6 degrees perspective, you guys are like the top of your game when it comes to service. Special mention to Keisha, Roe, Samantha. The reporting is good, right? I just showed you our reporting. 6 degrees will flood your inbox with reporting and data analytics. Dig into that. Email communications are tight, negotiations are good, follow-ups, consistency, helped us with successful deals, single case agreements, discounting, and obviously, again, proofs in the math, less than 1% balance bill. And by the way, we have clients employees and locations in Billings, Montana, and all these rural places where healthcare is not easy. Billings, Montana is a perfect example of a nightmare where the largest clinic got acquired by someone else. We had to kind of work through the one that used to take RBP. Now the new acquiring parent had to call the CFO. But it takes a lot of work, but the reward is huge. So, so when it comes to like the warm and fuzzy HR thing, right? We know this. We talked a little bit about Trump RX in the beginning and the beginning of the globalization and flattening of the cost of medications. It's often said, and I'm sure a lot of advisors on the call say this to their clients, your healthcare plan doesn't have a medical claims problem. Your healthcare plan has a drug problem. And the way we're addressing that is with script sourcing. So, this is a very, very big area. Reference-based pricing is by far number one when it comes to saving money on medical claims. And then the strategic work that you're doing to internationally source specialty medications is not too far behind at number two. So we've done this now since 2021. Our first script was sourced literally in July 21st of 2022. But this data is a little old, but not terribly old. But this one shows about 694 specialty medications with about $2 million to the plan. At a 10x, it's $20 million of OpEx or enterprise value. And so it doesn't just happen overnight. Just like the cooperation and collaboration with 6 degrees on the reference-based pricing, the script sourcing team leans in, whether it's the Manufacturer's Assistance Program, otherwise known as MAP, or internationally procured. We had it voluntary first to get it in. And so if you're going to get international drugs in motion for your clients, I always say start with voluntary, right? Because not everybody's going to be willing to adjust. But as it goes down and you show your client from a board perspective, from a C-suite perspective, the savings, change the SPD to mandatory. Sounds like an abrupt, excessive thing to do, but it's very well worth it. It changed our culture. It allows us to start campaigning directly to say, look, if you don't go the international way, you're not getting your medication. Sorry. And literally the CEO of Vensure is like, you know what? Hey, if it's going to cost me $200,000 through the plan, but it can be internationally sourced for less than 5,000, why in the hell would I ever have it voluntary? It's a good point. Thank God the CEO thinks the way I do. Education, 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 right? Constantly educating people. This is going to come to you through the mail. You were getting Wegovy before this way. It cost the company $2,000 a month, and you had to pay your deductible. And the good news is now you're going to pay no deductible, no out of pocket, and you're not going to pay anything for Wegovy. By the way, all these medications, one got stopped in customs. The day after it got stopped in customs, the employee received the second medication that came through. So a lot of people will complain, just like the people on LinkedIn where they're complaining about my bipartisan post about Trump RX. There's always complainers and negative Nancys and whatever. But there's no room for that because we need to get shit done. So when it comes to this, the HR teams engaged, they're tracking opportunities down. Hey, I see that you're on a high cost med. We want to help you. We want to remove this obstacle called deductible from you. And they're constantly emailing and campaigning. And by the way, it's also important to mention to your C-suite clients that you should incentivize HR people and C-suite people, incentivize them, right? If there's a portion, maybe it's a bonus, something that that client can give the internal people for the great work that they're doing to find savings for the company. So, um, kind of moving on a little bit, and we'll kind of maybe stop. And Heath, I don't know if I see that there could be some
There,
things in the chat, but
there's a question that came in around contracting. So
okay.
we can either go back in time or see if that comes
Yeah,
up on your slide deck
maybe
here in
we
a bit.
just address some questions. What do you think?
Yeah, well, I think there's just one. So everybody else, if you want, there's a Q&A tab. Click on that thing. Dan's an open book, and so am I typically. But um, we'll address those here. So, okay, I'm going to have you answer this from Vensure's perspective, and then I'll give an answer to kind of our philosophy on contracting, SCAs, et cetera. So, question comes in outside of SCAs, how often do you pull together full direct contracts with health systems? When you do, are those based on a percentage of MAP or complex PPO style, DRG, case rate, et cetera? What have you guys seen?
Yeah, so a good example of this would be like Orlando Health, or Self Regional, which is an institution up in Lower South Carolina. So both of those examples were where they were employees of ours seeking services, and first they weren't going to play ball with RVP at all. And so, in those types of scenarios, 6 Degrees still bring the advocate to call the hospital and negotiate a single case agreement. The hospitals will always be willing to do a direct contract, but it really depends on one variable, which is volume. Volume's everything to them. They're very unlikely they're going to do a single hospital agreement or a direct contract with the hospital with us as a very large employer unless they have commitments for volume. So, we're regionally spread across the United States. Maybe someday we'll have 50,000 employees. Even, in that case, you have more people to spread. So, in our particular situation, and Heath can probably speak to it on a larger magnitude, like some of the big national advisory firms that have bigger volume. But in our world, it's primarily just single case agreements.
Yeah, I mean, our philosophy is if you don't have to do a big global, let's not do it because you end up you don't want to put yourself in the PPO world, right? You usually have a diminishing return on your contracted rates, the bigger those contracts are. So if you can do it as a single case, that's preferred. However, there are times where it just makes sense. Mayo Clinic is an example where people are very passionate about getting access to Mayo. We've looked at their, build charge patterns. They're not horrible. And we decided that would make sense to have a contract there that all of our plans can access. So those are the types of things that we have to take into consideration. The thing we don't like to see is this, spur of the moment. Hey, we had one balance bill. It happened to be with a C-suite person. We need a global contract, right? And then you look at the data and you've got 900 other claims that have gone through at 140% of Medicare. Those are the things that you have to really dig into the data points and understand what makes sense. And we do offer the ability for plans to elect in to those types of things, so that we don't force all of our other plans into them. But that's more of a consult approach that we take to contracting with our advisors and plans.
Yeah, it reminded me of something too that proved to me that I think most of the advisors all know this, but it was proof to me because I've always asked the questions. Why I got in trouble in Catholic school. I was always in the principal's office more than I was in the classroom. But if anybody wants to ever know, DM me on LinkedIn. I'll tell you a funny story related to that. But what proved to me that reimbursements as a percentage of Medicare were completely arbitrary and completely artificial. So we have a client uses 6 Degrees. And in this particular state, the client serves on the board of the hospital. Very weird, rare situation, right? So he said, hey, when it comes to claims from our employees for this hospital, can you share those directly with me? Because I know the chairman of the board. I said, okay. So it was already an RBP positive provider, small local types of hospital, and claims are going along, and they were coming in like below the boundaries, the 220, the 190, things were going great. And I'm sharing with this CEO, hey, this is going good. This is exactly what you signed up for. This is what I thought. And all of a sudden, we had a claim come in at like 460% of Medicare. I'm like, what? This is an outlier, right? So I write up a narrative to him in an email, and I said, this is what you wanted if there's an outlier. Look, our net average is still very good, even if this slipped through, not to say that it would, because we want to fight for you. So he called me up and he says, well, good news. I said, what? He says, it's going to go down to what our regular average one is. I said, really? The client did the negotiation. So the client was sitting in a boardroom with the chairman of the board of the hospital. And he said, he held up the paper and all the other people were in the room were all board members. And he said, how is it that my employee health plan that averages this percentage of Medicare for you guys, and then you hit at me with this? It's 650% or whatever it was, like way. And he goes, look, just hand me the paper. We'll bring it down to whatever the average was before for you, so on and so forth. But to me, it was like, whoa, okay, this is crazy. It really, to me, means that network reimbursement in Medicare is totally artificial, totally arbitrary, and they could just move the levers wherever they want at any given time. And obviously, the commercial insurance companies created as everybody knows, it's been publicized, and you can watch documentaries on and so forth, that it's literally an organized scheme that these carriers have done to create large commercial reimbursements to bolster claims so that they could bolster premiums based on the old ACA. So like when you get into that type of a discussion with C-suites, the coast is as clear as it is behind me that your client should move forward with more of an RBP. In fact, when you leave the client, they're like, tell me more. They don't want to renew. They get mad. They get angry with what the status quo has been. So just to wrap up a little bit on the Vensure plan, it wasn't just about RBP or international drugs. Those again were one and number two. It's also about, like, as I mentioned, huge education with the employees, huge. But then when we uncovered that we had almost 128, I think the number was, I think it's on here, 124 diabetics in our organization, right? How can we help those diabetics? So we implemented with DiaThrive. There's a lot of great providers out there, but Mike Hennessy is running a brilliant organization. And this has come forward a few more years. I should have updated with the most current, but we had 75% engagement. I think most of that's because the HR people are very plugged into who's who. It's kind of rare in a lot of organizations. But 150 members expected to be living with diabetes, 112 were enrolled. We got a savings of almost $540 to $1,960 per person. We generated about $160,000 in savings, $142,000 in clinical event prevention. We have some financial measures there on the reduction in other incidences like hyper events, ER, endocrinologists that are being visited. And I happen to know quite a few people that are like close within the organization. One had an A1C, for anybody that's clinically geeky like I am, an A1C of 11. And so that is a clinically severe diabetic, non-adherent, non-managed nightmare. And through the help with DiaThrive, I'm happy to report that person today is under 5. So, through the work that they got with the education, the documentation that DiaThrive does, and the work that they do to be interactive, it's really helped us clinically manage the cost related to non-adherent diabetics. And obviously good reports come there and so on and so forth. Looks like there might be a question, Heath.
Yeah, another one in. Dan, I thought offering mandatory importation of foreign prescription drugs to employees or individuals is generally not compliant. Voluntary? Yes.
Yeah, so our program is voluntary. You're right. It's not under our SPD, it's mandatory, but we allow the person to have the first 2 fills of that as a traditional so we can pick it up. And then what we're doing is we're saying, hey, there's another program available to you. But I'm happy to report we've achieved 100% participation in that because of the way we educate with the rewards of doing it with no deductible, no out of pocket. And by the way, if you go to the FDA's website, employers are absolutely listed in there as you cannot, as an employer-sponsored program, import medications internationally. But under the FDA law, and trust me, we've had a lot of lawyers look at this, including the script sourcing's attorneys. We wouldn't do anything without being diligent. An individual American has rights to personally import medications from anywhere of the FDA-approved countries. So the script sourcing program is very individually focused and voluntary. Very important, very important. So sorry if I maybe miscommunicated, but it's not not in a sense of putting us in a compliant bullseye on that one. But good question. Last one I'll share, we've had 6 employees that have avoided musculoskeletal interaction by utilizing Regenix. And for those that don't know, Regenix is an amazing process where, they'll essentially pull blood plasma out and they do their science work with that. And they import that blood plasma, those stem cells, so to speak, into the joint, and the joint will naturally repair. It takes longer than usually people's patience for wanting a joint correction, but we've had tremendous improvement in employees, and we offered this in our 3rd renewal as 100% employer paid. So if someone takes Regenix or goes down that clinical path, there's no cost to them, which is a cool thing. Thoughts, Heath?
I'm not used the Regenix product, but I've heard people talk about it for a long time. I just, anything you can do to get people back recovered and not have to cut you open, I think can make a lot of sense.
Yeah, especially with I think it's like a crazy statistic. It's like 58% of orthopedic musculoskeletal intervention is unnecessary. I'm not saying that we're trying to tell our employees they can't get a, end stage degenerative hip replaced. We're not going to say, oh, you got to do Regenix first, but voluntarily, kind of like the international drugs, this is a great path. The last one, just to share, again, sharing some solutions providers, is we implemented Hint Connect this year. So we offered subsidized direct primary care to our employees. And so that, there's certain things that direct primary care can do. I've been an advocate of this for forever. Direct primary care doctors are also more educated about reference-based pricing plans. So when the patient or the employee who may or may not have a full understanding goes to their direct primary care doc, and the direct primary care doc says, hey, you need an endocrinologist, a hematologist, urologist, whatever it is, the direct primary care doctor has a greater understanding of how commercial insurance works than a standard hamster wheel primary care doctor. So it actually helps us advocate by bringing the person back to the plan properly for them to be able to call AIM, get the right recommendation. And again, the pursuit there is that they get rewarded by using providers that are part of centers of excellence. Then those doctors work with the DPC, and it's a more delightful healthcare experience than the obstacles that live in the way of traditional health plans today. So that kind of summarizes some of those additional point solutions that we've applied as a company, but we're also using in our consulting and advisory practice for the larger groups.
Yeah. Well, thank you very much for sharing all that information. I haven't seen any additional questions come in, but I'm just kind of curious, like if you were to go back and do it all over again, any fast tracks, tricks, or other things that you would have implemented from the beginning that you didn't?
Well, I mean, just a humble moment. Like I had to figure out how to get to a place where I had my own agency by working for someone else for a long time, right? So like if I were to be able to be in control of the steps to employee benefits, advisory, consultant, entrepreneurship, it would have been start my own from day one, even if it would have meant being broke and poor for longer, right? Because I didn't come from money. My wife and I, she worked in a daycare. I worked as a rookie in a PNC firm. And I remember selling my first couple large groups there and ultimately, driving more revenue than all the other PNC reps combined, and had to work hard to save money and put the kids through school and raise babies. And, that took a long, long, long time. And I think generations today are, I think our industry is in trouble because generations today are extremely impatient, and this business takes a lot of patience. So if I had to do it again, I would have probably just been as crazy as I was when I jumped off the agency I worked for 13 years and started my own, but I would have just done my own starting day one.
Yeah. I thought you were going to say, meet me sooner in the process, but that was a phenomenal background story as
Well,
well.
look, no. Like, I mean, truth be told, right? When RBP first, you guys started rolling that out, it was a little bumpy in the very beginning, right? It was a like, problems with balance billing, all that. But I think today, look, I was at this was the fourth year I got invited up to New York City for Forbes, and Mark Cuban was my guest this year, which was a lot of fun. And I met a retired hospital CEO out of Green Bay, one of the biggest hospitals up in the Wisconsin area. And I said, why is it? Because I knew they did. And I said, why is it that you're probably one of the most resistive hospital systems to reference-based pricing? What do you have against RBP vendors like 6 Degrees, right? And she was like, whoa. And she said, you know what? I don't have any resistance to it, but administratively, it just becomes one more payer for us. I was like, really? That's the answer? So she says, it's actually on my roadmap for my replacement CEO, for him to get mentors or get mentored on what are alternative payments. So I think the point there is as time, RBP needed a little bit of time, but now it's got really fast wheels on it. And I think it is absolutely a solve to what the nightmare is that we're experiencing as advisors when we're trying to coach our clients into, traditional carriers, and they're getting 30, 40, 50% increases. This is a great opportunity, right, to work with those clients and help them make change that's needed. So that's what I'm
Excellent.
thinking.
All right. Well, no additional questions have come in. I just want to thank you for everything you've done on this call and working with you over the years. So it's been a great relationship. I assume you're open for folks if they want to reach out to you and have a
1,000%. Yeah,
conversation.
connect with me on
Lindsay,
LinkedIn if you haven't. If anything, get a chuckle out of my Trump RX post and watch all the crazy bureaucrats responding and trying to pull me into a anti-Trump conversation, which again, I'm middle of the road for everybody's edification, but it's just silly to see the politicization of healthcare, which is sad. But maybe when Heath runs for president, I can carry his golf bag and I can help him out.
well, I got to start as mayor of my small little town first. There's a might be a position open soon. Hey, do we have any closing slides here with your contact information on it? And is Lindsay not running those today? Is that on your
I think I
laptop?
have, this is the one I had, but this is just really essentially just the questions one.
No,
But my
no,
contact
there you
info
go.
is
Look at
there.
that
But
handsome gentleman. There you go.
yeah, nice. It's an AI, and it's not really me. Actually, no, the funny real story is I use magnets when I wear a dress shirt. Today it's more of the casual, like polo with a jacket over it. But that picture, I had magnets on the inside holding the stand or the little stem things you put in the thing to make the collar. And when the picture came
Yeah,
through, it had that gray magnet in there. And our creative services guy made it the white dress shirt without the magnet, which I thought was pretty cool. But
that's
but
pretty
yeah,
cool.
my email for dan.thompson@vensure.com is my Venture email. But if anybody wants to reach me, it's the same inbox, but it's easier. Dan@thompsonrisk.com. They both go to the same place. And obviously connect with me on LinkedIn. I'd love to hear your input on some of these funny things and enjoy the entertainment of the bureaucrats that are responding to some of my healthcare posts.
Yeah, well, looks like we're gonna have a couple extra minutes here to go jump onto LinkedIn and join the banter. So,
Yeah,
all
nobody has
right,
time for that. I
everybody.
gotta get stuff done. But thank you, Heath. Appreciate you and the
Yeah,
tips you're
appreciate
giving me.
everyone being here for the May Fireside Chat. We will see you on the next one. Take care.